Today we're going to talk about rotator cuff related pain. Clinically, we cannot really differentiate between a tendinopathy, a partial tear, or impingement syndrome. Therefore, the use of such a term as rotator cuff related pain is often more appropriate. This is an umbrella term which describes a range of these conditions, which we'll look at each individually. In relation to impingement syndrome, this is more of a description of the mechanism of irritating subacromial structures. Today, we'll look into a condition called subacromial bursitis. We can see here on the right a diagram looking at the four tendons of the rotator cuff, and this is looking into the glenoid fossa from a lateral view. We're predominantly looking at the distal insertions of these tendons. Starting with supraspinatus tendon, coming around posteriorly and inferiorly, we have the infraspinatus tendon, teres minor, and finally subscapularis tendon at the anterior aspect of the glenoid. Starting with rotator cuff tendinopathy. Rotator cuff tendinopathy is caused by excessive load on the rotator cuff. This is often caused by repetitive movements in awkward positions, overhead positions. And so for athletes, this is often in swimmers and overhead shots in racket sports and throwing. Clinical presentation is a dull pain in the areas of the rotator cuff tendons exacerbated by overhead activity. Patients are also likely to report that they're getting weaker and ultimately can lose active range of motion and have pain at the end of range passive movement. Subacromial bursitis is often caused by an acute trauma, such as a fall or a knock, acute overload, such as a sudden increase in certain activities, including overhead lifting, or a chronic overload, including altered scapulohumeral biomechanics, functional instability due to rotator cuff weakness. Individuals will commonly present with a painful arc of movement of between 60 and 120 degrees. It's becoming apparent as more and more studies are completed that subacromial bursitis is an overdiagnosed condition. These three studies show that subacromial bursal thickening is often present in an asymptomatic population. And these findings are important when interpreting the results of imaging, noting that the changes in subacromial bursa may be incidental findings and not necessarily the root cause of shoulder problems. Remembering that imaging only makes up a part of the clinical picture. Rotator cuff tears. Now, when these are acute, they can be fairly obvious as they'll have signs such as bruising, swelling, and a marked loss of active movement, particularly for large rotator cuff tears. For example, you may be able to passively externally rotate the upper arm, but when released, the patient might be unable to maintain this position. Chronic tears are a little bit more difficult to diagnose from active range of motion because the patient is more likely to have adaptive strengthening in postures. Similar to the subacromial bursa, studies have shown that a high percentage of the population have non-symptomatic tears. So again, a tear seen on imaging needs to be correlated with the clinical presentation. Clinical assessment starts with observation and palpation. Marked atrophy is a strong indicator of a rotator cuff tear. Atrophy and fatty deposits in the musculature of the rotator cuff may also show up on ultrasound. If active range of motion is impaired in comparison with passive, it can be indicative of a muscle or tendon issue, including a rotator cuff tear. Famous impingement tests such as Hawkins-Kennedy or manual resistance testing, although very sensitive for rotator cuff related pain generally, cannot isolate individual muscles as all of the rotator cuff fires together and insertion of the tendons is very interconnected. These tests cannot be used to accurately diagnose a specific tendon problem, but may be useful in diagnosing rotator cuff related pain more generally. Conservative management in the acute phase of a traumatic tear would revolve around reducing inflammation and maintaining pain-free movements. The subacute to chronic phase is looking into restoring full range of motion, restoring scapulohumeral rhythm, and finally strengthening. Medical management can consist of a corticosteroid injection, remembering that the injection is only removing the inflammation. If the underlying cause of the inflammation is not addressed, then inflammation may just recur at a later date. Surgical interventions, depending on the age of the individual, the extent of the tear, and the extent of their limitations and symptoms, a surgical repair may be required. For example, a younger individual with a full thickness tear may be an excellent candidate for surgery. For an older individual, and often a trial of conservative treatment is recommended.